Thank you. Good evening to one and all, and regards and good evening to Dr. Mary Abraham too. Uh, with all pride and privilege and pleasure, I would like to introduce Dr. Mary Abraham, who is a neuroanesthesiologist and a pain and palliative care physician. She is a visiting consultant in many hospitals in New Delhi, and she's been awarded the Lifetime Achievement Award by the Neurological Association for her contribution to neurosciences in Delhi in February 2017. And her main interests are neuroanesthesia, pain, and palliative care. Both are essential and very important specialities. And she's also authored a book, Conquering Pain, in 2019. And pain is one of the important elements of palliative care. And so we have an eminent person to take you all through this session. The floor is open to you, madam.
Thank you, Radha, for such a kind introduction. And thank you, Shripriya, for coordinating this. And once again, it's a very, very happy to be here. But can you just give me a minute before I can just open my slideshow?
Yes, madam. Yeah, get yourself comfortable and let us know.
Thank you so much. And today I will be focusing on the pain management with the basics of WHO analgesic ladder, the step 1 and 2 of the analgesic ladder. And also I'll be focusing on adjuvant drugs and drugs for neuropathic pain. So what is a WHO analgesic? This analgesic ladder was devised based on the recommendations of a group of national experts way back in 1986. It's nearly 30 years and still it is very popular, and we are still implementing it in not only in cancer pain, but also in the acute pain management and also in non-cancer. And it has been so successful that it's been translated into many languages, and it is serving as a catalyst to treat cancer pain worldwide. So this is a stepwise approach to treat pain, depending on the severity of pain. So prior to the ladder, people were dying of unnecessary pain for two reasons. First of all, there was a lot of drug regulation associated with the use of opioids. It was very difficult to, not only prescribe it, but also store it and manufacture it. And for people to get access to it also, it was very difficult because of all these drug regulations. And also there was a stigma associated with taking opioids, strong opioids, and even prescribing it. And relatives also did not want their loved ones to take morphine. They themselves felt that they would become addicts. So all this was a barrier to prescribing. But when the WHO itself endorsed this ladder and wanted it to be implemented, it was actually legitimizing the use of opioids. And many of these barriers were blown away after this. So to start with, let me start with the case scenario. A 35-year-old father of two young kids. He had squamous cell carcinoma in the right upper lobe, lung. Pain was deep-seated, gnawing pain, the right shoulder, with a burning and tingling sensation in the right arm. He was unable to sleep at night. During the day, his NRS was 4/10, and at night it was 6. Now, before you implement the ladder, the ladder is dependent on the fact that we need to assess the severity of pain. Because based on the severity, we are implementing the ladder. So a comprehensive assessment of pain is a must before you can think of starting the treatment. So you're all familiar with the PQRST, the comprehensive assessment factor, and I will focus on this severity of pain. So that is what you need to know before you implement the ladder. Now, not only severity, you also need to know the type of pain. Is it a nociceptive pain, or is it a neuropathic pain, or is it a combination of both, which is mixed? Now, we all know that nociceptive pain is because of tissue damage, and neuropathic is because of a lesion or disease in the nervous system. I'll talk about it a little later. So this is also very essential when you need to implement the ladder, because depending on that, you must have to add an adjuvant. Now, the ladder is a three-step ladder, the original ladder. Okay? In step one, it is used to treat mild pain, where the NRS score is less than 4. And so you can give a non-opioid analgesic with or without an adjuvant. If the pain is not settling down with this one, then you need to go up the ladder to step 2. So step 2 is given for moderate pain, where the NRS is between 5 to 7, approximately. So then you have to give, in addition to your non-opioid and adjuvant, you need to add a weak opioid. Now, if it is not settling with this also, then you go up the ladder to the step 3, which is when you substitute the weak opioid with a strong opioid, along with or without a non-opioid or with a. Sometimes the pain is very severe, you can straight away move to the step 3. If the pain is, around 8 or 9, or unbearable pain, and the patient is crying with pain, you don't necessarily have to go up the ladder. So, but that's a way of doing it, which will be dealt with when you're dealing with the step 3. That is the titration of the opioids before you give the actual dose of opioids. Now, using the step ladder approach, nearly 71 to 76% of cancer pain can get satisfied. That's a huge chunk by just implementing this ladder. A large majority can get fairly good relief. Now, what are the salient features of the ladder? Please remember 3 basic things. It is by mouth, by ladder, by cloth. First thing. Now, by mouth means the oral route is a standard route even for the strong route. And this is a big advantage because it can be given at home, it can be given by the caregiver of the patient, it can be given by the nurse who's visiting, the domiciliary nurse. So the patient doesn't have to be hospitalized when you're giving these analgesics by the WHO lab. So that is one big advantage. The second thing that we need to remember is by the ladder. Like I told you, you start off with step 1 and then you move up the ladder, depending on the severity of pain. But like I said, you can even start with step 3. Third important characteristic, it is given by the clock. That means the pain is given depending on the drug is given depending upon the duration of action of that particular analgesic. For example, if it's morphine, the duration of action of the immediate release morphine is only 4 hours. So that means the next dose of morphine is given at 4 hours. So if you tell the patient, you take it at 6, then you also have to tell him the next dose is at 10, and then at 2, and then at 6, and then at 10. So it is given by the clock. Now, it depends upon the analgesic that you're giving. For example, if you're giving paracetamol, it's given every 6 hours. That's the half-life of the paracetamol. Or you're giving, say, selective non-steroidal like eucoxia, which is called etoricoxib. You give it only once a day. Piroxicam, like today, I was looking at the case presentation. So the person had mentioned that its duration, half-life is 50 hours. I also didn't know that it's that long. I knew it is long, but I didn't know it's 50 hours. So you give it according to that. So you don't give it when the pain appears. Because if you do that, then it causes what is called a breakthrough pain. And that will totally spoil your regime. Because if the patient is having pain in between, then the patient is not comfortable. So you not only have to treat the continuous pain, you also need to treat you have to make sure that the pain relief is continuous with no breakthrough. That can happen only if you're giving it by the duration of action of the drug. Then it is individualized to the patient. So the right dose is the one that relieves the pain. It doesn't matter if you're giving 60 milligram morphine in one patient or 300 milligram morphine in another patient. Because only with 300, he is getting pain relief, and with 60, this guy is getting a pain relief. So it depends upon the patient, their own thresholds, upon the severity of disease, and so many other factors are there. So the right dose is the one that relieves the pain, immaterial of the total number of tablets a patient. And also you need to specify what do you do for breakthrough pain. The patient in between 4 hours of morphine has pain, then you must tell them what to do so that there is no breakthrough pain. So it is very individualized. The other characteristic is that you use adjuvant drugs, which I've shown that at every step you can add an adjuvant drug for different types of pain other than nociceptive pain, or to decrease the undesirable side effects of the analgesic. And attention to detail is very important. The patient's age, the body habitus, the comorbidities, and the body weight, the side effect profile, everything has to be meticulously monitored. Now, the advantages of the WHO ladder is that it is simple, very easily understood. It's a validated tool. That means it has been found to be effective, and it is also very cost effective. Because the drugs like morphine and methadone are very inexpensive drugs, can easily afford, patient can afford them. It can be implemented across the world, even in underdeveloped countries. It's well suited for home care, like I told you, and it can also be given for acute pain and chronic pain. Sometimes, like I mentioned, you can omit certain steps and go directly to step 3, or sometimes you may have to add a 4th step to treat pain that's not responding to the 3rd step of the ladder. So this was somewhere in 2000 where the WHO analgesic ladder was modified to add the 4th step. In the 4th step, it is used for those patients, like 10 to 15% of patients who are not responding to the 3-step ladder. So what do you do for these people? You can give additional nerve blocks, you can give epidural, you can give a patient-controlled analgesia pump, or neurolytic block, spinal cord stimulation, or intrathecal opioids. That we can discuss when you're treating interactive. Now let's discuss step 1. So step 1 drugs I mentioned is used to treat mild to moderate, and they include paracetamol, also known as acetaminophen in the Western countries, and non-steroidal anti-inflammatory drugs, and it can be combined with an adjuvant. Now, paracetamol, its predominant action is a central action. It inhibits the enzyme cyclooxygenase, or COX, in the central nervous system. It does not have effect on the peripheral COX. And because of that, the side effects of paracetamol are less as compared to the NSAIDs, because NSAIDs acts on the peripheral COX. Now, paracetamol has predominantly antipyretic analgesic action. It does not have any anti-inflammatory. The dose of paracetamol, safe at doses of 12 to 15 milligram per kg every 6 hours, can be given up to 3 grams a day and should not exceed 4 grams. And a single dose should not exceed 1 gram. The normal dose is usually 650 mg. We also have paracetamol sustained release tablet. That is 1 gram, out of which 300 is released immediately and 700 is released over the period of 12 months. So you can also give that addition. Then you can also give paracetamol as an infusion, 1 gram every 6 hours. You can give it rectally also, particularly when the oral route is not fixed. Certain types of cancer, like head and neck cancer or cancer of the mouth, or when the mouth opening is limited, or cancer of the larynx where they cannot swallow, then you can use a rectal route as well. Safe for pediatric use in a dose of 15 milligram per kg every 6 hours. And toxicity occurs only in doses of more than 90 milligram per kg. Now, we should know a term called NNT. NNT is the numbers needed. So, NNT tells you the efficacy of a drug. For example, the NNT of paracetamol 650 milligrams is 5. That means if it's a number of patients who receive the drug for one to have 50% pain relief over the next 6 hours. So if you're giving 5 patients paracetamol, then one will have good. So it means that if the NNT is low, the drug is more strong. Analgesia is more efficacious. For example, Brufen and diclofenac have a lower NNT as compared to paracetamol. So remember, the NNT of paracetamol is 5. Now, what are the advantages of paracetamol? It has got a good side effect profile, like I mentioned, because it acts on the central cyclooxygenase. It has no adverse effect on gastric mucosa, well tolerated by patients with peptic ulcer, no adverse renal effects, no effect on platelet function, so it does not cause bleeding problems, tolerated by those who are hypersensitive to aspirin, and it does not affect the plasma uric acid. But the drawbacks are that it has to be given every 6 hours, it has no anti-inflammatory effect, and there is a potential of hepatotoxicity. But that is only when you give doses of more than 4 grams a day, those with impaired liver function, those who are excessive consumption of alcohol, whose body weight is less than 50, then you must reduce it to 2 grams. But even in liver disease, you can go up to 2 to 3 grams a day. In cancer pain, it is one of the mainstay drug of the WHO analgesic ladder. It's given at every step of the ladder. Good safety profile, and it has an opioid sparing effect as well. And it also can be added to non-steroidal NSAIDs when its NNT will improve to 2, or tramadol or opioids. So it can be added at every step of the ladder. Now we come to the non-steroidal anti-inflammatory. So like I mentioned, these drugs exert its therapeutic effect by inhibiting the peripheral cyclooxygenase. Now, this enzyme is a very important enzyme in the arachidonic acid cascade, which ultimately produces the tissue and the inflammatory prostaglandins. Now, we all know that prostaglandins are the important intermediaries in pain and inflammation. And they mediate pain because of a phenomenon called peripheral sensitization. Now, peripheral sensitization is a one that amplifies pain. Okay. So when the peripheral nerve ending is, when there's a tissue damage, these anti-inflammatory substances are the ones which are released by the tissue, and it is causing a sensitization of the peripheral nerve endings. And that is what happens with the inflammation. If you look at this, now this is a tissue damage that has occurred. Now, there is release of all these substances. These are the inflammatory mediators. They form what is called a sensitizing soup around the peripheral nerve ending, which is a nociceptor. Okay? And it increases the excitability and irritability of the nociceptor, and it amplifies the pains. Here also you can see that this is a tissue damage. This is all these inflammatory mediators. They form a soup, inflammatory soup around the peripheral nerve ending, and it causes amplification of the pains, which means the more the tissue damage, the more the peripheral sensitization. And these anti-inflammatory, non-steroidal anti-inflammatory drugs like COX inhibitors act at this level. It's acting here to decrease the amount of prostaglandin that is released. So like I mentioned, when there's tissue injury, there is a release of phospholipids, and there is produces arachidonic acid, which is acted upon by the COX-2 enzyme and causes the prostaglandin. And that is the one that causes inflammation. So the cyclooxygenase enzyme exists in 2 forms. One is COX-1 and one is COX-2. Now, COX-1 is normally present in the human body. It is called the constitutive or the housekeeping enzyme, and mediates all the physiological responses like protection of the kidney, stomach mucous membrane, the kidney, and facilitates platelet aggregation. Okay. So this is a beneficial enzyme. But if you give an anti-inflammatory drug, because it inhibits COX, it is also inhibiting this, and that is why you have the undesirable effects of. But because it is inhibiting the COX-2, it is decreasing the amount of prostaglandin that's released, and it causes that anti-inflammatory. So now if you look at it, the COX inhibition produced by NSAIDs can inhibit both the COX-2 and the COX-1. COX-1 is undesirable, but COX-2 is the one that produces the analgesics. Please remember. So this is there normally in the body. This is induced only when there is a tissue injury that is induced. It's not normally present. Now, non-steroidal anti-inflammatory drugs exist in two types. We have two types. One is the non-selective, which is interfering both with COX-1 and COX-2. It has the undesirable and also the beneficial. And the selective COX-2 interferes only with COX-2. Now, if you look at the classification of COX-2, non-selective COX inhibitors, you have the salicylate, which is aspirin. You have the propionic acid derivatives like ibuprofen, naproxen, ketoprofen. Then you have diclofenac. It can also be functionally a COX-2 inhibitor, but it's classified as a COX. Then you have piroxicam, ketorolac, indomethacin. So these are some of the COX-1 and the non-selective or the one that inhibits both COX-1 and. So how do they act? Like I said, the inhibition of the COX-1 causes the adverse effects, like I told you, the GI side effects, the hypersensitivity reaction, and the adverse renal. Inhibition of COX-2 will produce the beneficial. So these non-selective COX enzymes, COX inhibitors it's like a double-edged sword. It has got both adverse as well as beneficial effects. So the example of that is ibuprofen, which has got an NNT of 2, or naproxen, which has an NNT of 2.7. So they are very good analgesics. Like I said, these are the side effects. I won't go into that. Now coming to the selective COX-2 inhibitors, they're only inhibiting the COX-2. It is not interfering with the COX-1. The examples are etoricoxib, popularly called Eucoxy or Eucoshine, given in once a day dose, or celecoxib, which is 100 or 200 mg twice. And like I mentioned, diclofenac is functionally a COX-2 inhibitor because it has not much side effects on the stomach. But it has got adverse effects. The dose is 50 milligrams every 8 hours, and the NNT is very good. It's 2. Now, NSAIDs can also be given topically. They produce an analgesic effect without less systemic absorption. Gels, creams, and sprays are available. You have diclofenac, piroxicam, or ketoprofen available as for topical action. Transdermal NSAIDs is also available. Diclofenac patches of 200 mg is available. Should be given every day. Every day. This brand is blue patch. Now, are selective COX-2 inhibitors safe as compared to non-selective COX inhibitors? Like I said, it is only safe for the GI as compared to the non-selective. But the renal damage is comparable with both. On the other hand, the non-selective COX inhibitor, the selective COX inhibitor can have a prothrombotic effect. So there is more likelihood of myocardial infarction and stroke. And one particular drug called rofecoxib was taken off the market in 2004 because of the incidence of these adverse effects. So in such patients who are high risk for atherosclerosis, you can give drugs like ibuprofen and naproxen, particularly in the high risk type. If you look at the risk factors for NSAIDs toxicity, for GI toxicity, you should avoid it in all these situations. For renal toxicity, remember, patients should be well hydrated. And advanced stage, you have to be very careful. And if there are risk factors for stroke and MI, like history of TIA or stroke, or history of MI, hyperlipidemia, diabetes, advanced stage, then you should avoid the COX-2. Now coming to the step 2 drugs. Step 2 drugs are given for moderate pain, not controlled with step 1. Now they are weak opioids, which means they are not controlled drugs like strong opioids, and they can be available even without the DD12 form. They can be available from the is the prescription. But sometimes you don't have to give it. You can even skip it. The drugs that I will discuss, which is being used, is tramadol and temadol. Now, coming to tramadol, it is a synthetic weak opioid. Okay. And because it is a mu opioid receptor agonist, it has less tendency for respiratory depression and addiction potential as compared to morphine because it's a weak opioid. Also has another method of action, that is a non-opioid effect. It blocks the presynaptic reuptake of serotonin and norepinephrine. So it acts on the descending inhibitory pathway. So this particular advantage of tramadol is because of the second method of action, it can be given for neuropathy as compared to the NSAIDs. It is a prodrug. That means it is converted to an active metabolite for its analgesic action, the enzyme cytochrome. And combination of tramadol and paracetamol is very commonly used. It's got a high oral bioavailability. Plasma half-life is 6 hours. The oral dose is 1/10 as potent as. For example, you're giving 400 mg tramadol. You divide by 10 and you'll know the equianalgesic dose or the morphine. Dose is 50 to 100 mg every 4 hours, maximum up to 400 mg, and you also have sustained release formulations, which can be given twice. The side effects, it can cause nausea, vomiting, dry mouth, constipation, dizziness, sedation. There is a risk of seizures when the total dose exceeds 400 mg, or you give it with drugs that lower the seizure threshold, or when you're giving it rapidly. So when we give tramadol IV, we usually give it over 10. Maybe you can add an anti-emetic. Now, tapentadol is the other weak opioid. It's very similar to opioid binding studies have shown that it is actually a strong opioid. It's not a weak, although it is traditionally classified as a weak. In fact, you can see that 75 mg of tapentadol orally is equal to 30 mg of. It again has a dual method of action, just like tramadol. It's a mu receptor agonist, and it also acts on the inhibitory pain pathway. It can also be used for neuropathic. It is not a prodrug, so there are no active metabolites. The dose is 50 to 100, same dose as tapentadol. Again, everything is the same. The maximum daily dose is 600 mg, but the side effect profile is less as compared to the tramadol, and the less risk of seizures is also less. Avoided in severe renal hepatitis. Now, if you look at analgesic combinations when you give, very often we use combinations. So just remember, a thumb rule is never use 2 drugs of the same category for treatment. Like you don't combine a weak opioid with a strong. So, or you don't combine a COX-1 with a COX-2. But these are the combinations that are favorable and which will have not only a less side effect profile, but it also enhances the efficacy of each. Now, we let us shift gears and move on to neuropathic pain. That's important to know because I said we have to add adjuvant drugs. So we know that cancer pain can be not only nociceptive, that is because of the tissue damage, can be because of muscle spasm, it can be because of a neuropathic component or bone pain or bowel obstruction, or there could be other associated symptoms. And neuropathic pain is present in 40% of cancer. And that is why you give these adjuvant drugs to treat all these different kinds of pains. So adjuvant drugs have analgesic properties, but the primary indication is not for pain. For example, when you give an antidepressant, its primary indication is depression, but it is also given as an analgesic because it's good for neuropathy. Similarly, anticonvulsant. It is not, its primary action is an anticonvulsant, but it has got effect on pain. So they are also called co-analgesics. So if you look at the classification, it's based on the clinical symptoms. You have the multi-purpose drugs like antidepressants, corticosteroids, or alpha-2 agonists. And then you have the neuropathic pain drugs. So these are all the drugs that can be given for neuropathy. And then you have the adjuvants for bone pain, the adjuvants for bowel obstruction, or for musculoskeletal. I'll try to go through that. Now, when you look at the type of pain, I told you in the beginning that there are two types of pain, nociceptive and neuropathic. Now, nociceptive is because of tissue damage at the periphery, right? Anything beyond this comes under neuropathy. So, the primary afferent neuron or the first order, the dorsal horn, the spinal cord, and the brain. Any lesion in any of this part will cause a neuropathy. And that is a definition given in 2018 by the IAS. But cancer pain is not either nociceptive or neuropathic. It can very often have a combination of both. That is why it's very important to know not only severity of pain, to know which drug you give, but also the type of pain, because then you have to add other drugs like. Now, I told you the incidence is as high as 40%. It can be because of the direct invasion or compression of the nerve because of the cancer, or it can be because of the treatment of cancer. For example, chemotherapy induced peripheral neuropathy. It damages the peripheral nerves and causes a CIPN, or it can be radiation induced. Also be because of injury to nerve during the surgical excision. Sometimes it is even seen in cancer survivors for months or years because of the permanent nerve damage that the chemotherapy drug has caused on the not only chemotherapy, even radiation. The pain can occur even after the patient is cured of the cancer. So the first line treatment for neuropathic pain is anticonvulsants. Now, why are anticonvulsants given for neuropathic pain? Because there's a shared pathophysiology between epilepsy and pain. In both, there is neuronal hyperexcitement, and anticonvulsants dampen this neuronal excitement. And these are the commonly used. How do they act? Now, these gabapentinoids, as they are called, are act at this site here. It binds to the voltage-gated calcium channel, that is particularly the alpha-2 delta subunit of the calcium channel, and prevents entry of calcium to the presynaptic. Now, once this is prevented, then the release of the excitatory neurotransmitters like aspartate and glutamate and all are decreased. Okay. And when this is decreased, then the excitation of the postsynaptic membrane is also. So that is one way of acting, by acting on the calcium. It also acts on sodium channels, and it also enhances the GABA-mediated synaptic. We know that GABA is an inhibitory neurotransmitter, and it actually enhances the inhibitory. So the two commonly used drugs are gabapentin and pregabalin. They have got a proven effect in neuropathic pain, well tolerated, less chances of drug reaction. But the side effects should remember, and this should be told to the patient. Somnolence, dizziness, ataxia, fatigue, impaired concentration, weight gain. So I last week I told a patient that I'm going to start on pregabalin. When I told her about weight gain, she says, I don't want any drug that increases. So I had to tell her that you need to take it because that's the only way you can get pain relief. But it's very important to explain it to the patient. Now, this is gabapentin is less expensive than pregabalin, but it requires a slow titration as compared to pregabalin, because pregabalin can be titrated in just 2 days, more expensive. Now, there are topical drugs that can be given for neuropathy. One is topical gabapentin is now available, and you can also use topical capsaicin. Now, capsaicin is a pungent component of chili pepper, not freely available in India. Now, the capsaicin patches are available, and a single patch can produce pain relief. You apply it for 30 to 60 minutes, and it produces pain relief even up to 12 weeks, they say, 8% capsaicin. Now, coming to the antidepressant drugs. Now, this is also the first line treatment for neuropathic pain, just like anticonvulsants. So you can give either anticonvulsant or antidepressant or both. But the analgesic action starts in a week's time. So you have to explain to the patient that this is not instantaneous. And this analgesic effect is not dependent on the antidepressant effect. It occurs earlier and also at lower doses as compared to the antidepressant. So when you give an antidepressant for neuropathic pain, has an added benefit because these patients are frequently depressed, anxious, have insomnia. So they are very much benefited by these antidepressants. Now, mode of action, how do they act? They inhibit the reuptake of norepinephrine and serotonin at the dorsal spinal cord synapses. So they actually activate the descending inhibitory pathway. Now, the antidepressants in clinical use are tricyclic antidepressants like amitriptyline, nortriptyline, SSRI, which is a selective serotonin receptor inhibitor, like escitalopram, citalopram, paroxetine, fluoxetine, sertraline. Or the SNRI, that is a selective serotonin norepinephrine receptor. It inhibits both serotonin and norepinephrine, the drugs that's commonly used is duloxetine and venlafaxine. Then you have a new category called NASA. Okay. That is noradrenergic alpha-2 receptor antagonist with specific serotonergic receptor. They are mirtazapine, so that's also being used. You also have atypical antipsychotics. Like quetiapine, risperidone, or olanzapine. They also help, particularly when the patients have delirium and hallucinations. So what are the antidepressants that are commonly used in cancer pain? The three types are, I'll only talk about these three. That is a TCA. It could be either amitriptyline or nortriptyline. This has got lesser side effects as compared to amitriptyline. Amitriptyline is popularly called tryptamine. Or you have the SNRI. They are duloxetine or venlafaxine. Or you have the SSRI. Now, SSRI is basically more of anxiety and depression as compared to analgesics. So, what the patient has got a lot of pain, then SNRI is preferable to SSRI. But it can be given in combination also, particularly if there's anxiety. If you look at the analgesic efficacy, TCA is stronger than SNRI, is stronger than SSRI. But the side effect profile, TCA has got more side effects as compared to SNRI. Now, you should also remember the side effects when you're prescribing these. The CNS side effects, somnolence, drowsiness, mental clouding, and suicidal tendency. The anticholinergic effect also is very important, the antimuscarinic effects. Very often they complain of dry mouth. It can precipitate glaucoma, blurred vision, tachycardia, urinary retention, constipation, orthostatic hypotension. All these are important. So, contraindications for TCA are those with heart disease, or those with prostatic hypertrophy, or those with narrow ankle. Avoid this. Now, coming to the SNRI, again, these are all the CNS side effects. Okay. But the contraindications are that venlafaxine you should avoid when there's hepatic and renal insufficiency, and duloxetine when there's a hepatic. If you look at the dose administration of these drugs for neuropathic pain, antidepressants are amitriptyline. You start off with 10 milligrams, and then you can go up every 3 to 5 days, 25 mg, 50 mg, up to 100. Nortriptyline, again, you start off with 10 mg. Duloxetine, you start with 20 or 30 mg, and then you can slowly increase it. And venlafaxine, you start off with 37.5 mg. And anticonvulsants, again, gabapentin, start off with 100 mg at night. Remember, give it more at night. All these drugs, I tell my patients, take it before 8 o'clock at night. Because then the drowsiness effect will wear off by the morning, and they can carry on with their normal activity. Otherwise, if you tell the patient to take a drug at night, they will take it at 11 o'clock, 12 o'clock when they're going to sleep. That's not the right. These are the various drugs that you can give. Remember, all drugs you must adjust for medically ill patients and those with. Now, duloxetine has been given in a trial in patients with chemotherapy-induced neuropathy. And they found that when you give duloxetine as an initial treatment in weeks 1 to 5, there was lesser incidence of the CIPN as compared to the placebo. So they say that duloxetine can be used for the initial treatment of painful CIPN. What are the other drugs that can be used in neuropathic pain? I told you about this. So there is this NMDA receptor, which is there in the dorsal horn of the spinal cord. So ketamine can be given for difficult neuropathic pain. It acts at this, acts by blocking the NMDA receptor. I'll talk about it when we discuss the difficulty. But it has side effects. Ketamine side effects are dysphoria, hallucinations, and so on. And you can prevent it by adding a benzodiazepine or a haloperidol. It can be given in a variety of routes: IV, IM, subcutaneous, oral, sublingually, intranasal, rectally, topically, intraarticular, epidural, intrathecal. The oral bioavailability is 20% after 30 minutes, but the IM bioavailability is very high, 90% at 5. So it can be given intramuscular. Now we know that it's given sub-anesthetic. It's basically an anesthetic, but in sub-anesthetic doses, it has got analgesic. So oral ketamine has been used in a dose of 10 to 25 mg TDS, the whole set. And also you can give subcutaneous or IV ketamine up to 200 mg per day in a syringe. Now there's also a burst ketamine infusion, which we use for difficult pain, which I'll talk about. Local anesthetics can also be used for difficult pain. They act by decreasing the neuronal excitability at the level of the sodium channel. Good for neuropathic pain, particularly the severe intractable crescendo kind of. It can be given as an IV local anesthetic infusion. Xylocard is the one that is used, 5 milligram per kg over 1 hour as an infusion with cardiac in the hospital setting. Topical local anesthetic patches are available now, 5% lidocaine patches. You have to apply, up to 3 patches can be applied, but you must keep it only on for 12 hours and then remove it for the next 12 hours. Otherwise, you can have. The other drugs used to treat neuropathic pain, like I mentioned earlier, are topical capsaicin and topical. If you look at the first line of treatment of neuropathic pain, they include amitriptyline, pregabalin, gabapentin, duloxetine, and lidocaine. The second line of treatment are opioids like methadone or tramadol, and the third line are baclofen, mexiletine, capsaicin. Now coming to steroids. Steroids is a multi-purpose. It can be given for a variety of pains. Yes. So neuropathic pain, bone pain, headache because of ICP, based ICP, because of a secondaries, can be given for arthralgia, for hollow viscous obstruction, or capsule distension, and also for pain during spinal. If you look at the various steroids that are available, you have hydrocortisone, prednisolone, dexamethasone. Now just see how potent dexamethasone has got anti-inflammatory action 25 to 50 times as much as hydrocortisone. And also its plasma half-life is duration of action is 36 to 54 hours. So it's got a long duration of action. So it's given once a day dose. Because of that, it's a first-line drug, potent anti-inflammatory effect, and less mineralocorticoid. So less chances of sodium and water. But steroids should always be given in the morning, because otherwise they can get insomnia if you give it at night. And particularly in those with less life expectancy, steroids can provide short-term relief of pain with a general feeling of well. Here, these are the doses of dexamethasone for various kinds of diseases in cancer. For meds, you can go up to 4 to 8 milligrams for us. You can go up to 16. For malignant bowel obstruction, you can go for 6 to 16. For an appetite stimulant in cancer also. Now, GABA receptor agonists. It's another category of adjuvant drugs that you can. How do they act? They potentiate the inhibitory effect of the GABA, which is an inhibitory neurotransmitter. I've got about 3 minutes left, I think. So this is an inhibitory neurotransmitter. So the agonist actually potentiating the effect of GABA. Now GABA exists in 2 forms, GABA A and GABA B. GABA A include the benzodiazepines, out of which clonazepam is the one that is useful for neuropathy. And GABA B receptor agonist is baclofen. Now coming to clonazepam, given in a dose of 0.5 milligrams for neuropathic pain. It's also given for sedation for pain patients with cancer. Not terminal sedation, routine sedation for insomnia, can give in a dose of 250 microgram or 0.25 mg. Or you can even give it for terminal sedation in a dose of 500 mg microgram, or even as a continuous subcutaneous infusion of 2 to 8 milligram. Now, GABA B agonist is baclofen. Okay. So it has got a variety of effects, particularly in neuropathic pain. It's also for hiccups and musculoskeletal spasms. So you start off with 5 mg and you can go up to 20 mg. Now, bone pain. Bone pain is because of the metastasis, the cancer. And they are called skeletal related events. They can cause fracture, they can cause pain even without fracture also. So that pain is very agonizing and it affects the quality of life. So the various drugs and agents that can be given for bone pain, corticosteroids and non-steroidal anti-inflammatory drugs for multifocal bone pain. You can give calcitonin, but the latest reviews show that it does not produce a significant improvement in the quality. They are all osteoblastic. They improve the bone form. The bisphosphonates and dinosab also are now very commonly used to treat bone disease and bone. They inhibit the osteoclast-mediated bone reception and reduces the skeletal related and then palliative. So bisphosphonates, I said it's used, it blocks the osteoclastic activity and the bone resorption. The drug that is commonly used is zoledronic acid. 4 milligrams is given in 100 ml of normal saline or 5% dextrose over 15 minutes every 4 weeks for 1 year. But it has side effects like pyrexia, renal dysfunction, and osteonecrosis of the jaw. And if the patient has renal dysfunction, then you must use it. Now, if you compare zoledronic acid and denosumab for bone, this is definitely more cost effective, very, very expensive. This can be given IV, this is given subcutaneous. There's more risk of renal toxicity with zoledronic acid and less risk of toxicity. But there is an increased risk of hypocalcemia, but it is superior to prevent the skeletal related events, and it has got a better median survival rate as compared to the. Look at the cost of drugs. I said this denosumab is very expensive. Cost per month is 32,000, whereas the zoledronic acid is just 900. Then you have the palliative radiation, and this is very good for, particularly when there's a focal area, you can give a palliative radiation. Now, malignant bowel obstruction can use steroids to decrease edema in the bowel. Octreotide is a somatostatin analog, and it decreases the intraluminal secretions and the peristaltic movement, so it is effective for bowel obstruction. And also anticholinergic drugs like hyoscine butyrate and glycopyrrolate, or you can give a combination. The other adjuvant drugs are the skeletal muscle relaxants or neuroleptic agents like olanzapine, antibiotic sedative, anxiolytic. So if you look at the where they act, the various analgesics and adjuvant drugs, see, this is where your muscle relaxants act at the muscle level, the neuromuscular junction. Now, local anesthetic and topical analgesics and all act by preventing, and NSAIDs, they act by preventing peripheral. So even here, you have the NSAIDs acting at the peripheral. Now, anything beyond this is neuropathic pain. So, drugs like anticonvulsants, antidepressants, NMDA antagonists all act at this. And there are also certain drugs that act on the descending inhibitory pathway. This is a descending inhibitory pathway. They include the TCAs, the SNRI, the tramadol, tapentadol, certain opiates also, and the alpha-2. Now, coming back to our case scenario. Here we had this patient, which we had already explained in the beginning. So how do we treat this gentleman? Now his pain was intensity-wise, it was only mild to moderate. The type of pain, he had both nociceptive and a neuropathic pain, right? Because the pain was radiating down his arm, which was burning and things. Now the pain was worse at night, so that's a temporal nature. And to unveil the meaning of pain, he had functional component, emotional, social, and financial. He was unable to sleep. He was a father of 2 young kids, and that also was aggravating them. So how do we give treatment? We can give a combination of paracetamol with NSAID, that is step 1 of the ladder. But we can give a higher dose at night because he has got pain more at night. NRS more at night. So at night, you can give either paracetamol 1000 mg or you can give a slow release preparation like diclofenac. You can add an anticonvulsant and antidepressant for the neuropathic part of it. And you can add an adjuvant drug like a sedative so that he gets better sleep. And also you must give psychosocial financial also. Summarize, the WHO analgesic ladder is a sheath anchor for cancer pain management. Can also be used for non-cancer pain. It's simple, easy to implement all over the world, and most important, it is legitimized the use of opioids in cancer. And thank you.
Thank you, Madam. An extensive and detailed explanation of what is essential, because this is the basic what they're going to start off with and move forward. And open to, like, we can have discussion for a few minutes and then go on to the case. Please either type in the chat or unmute and you can ask, please. Either way is fine.
Madam, I'm Dr. Narayan from Mangalore. I got one question. So you
Go
told
ahead,
that
go ahead.
You told that there are several types of NSAIDs. But for what type of pain, what type of NSAIDs should be given, madam?
See, if there is an inflammatory component, you can give a non-steroidal anti. But it's, like I was thinking, there are certain drugs that are given more when the patient has rheumatic pain. But for cancer pain, since we are focusing on cancer, the non-steroidal anti-inflammatory drugs that is commonly used is either a COX-1 or COX-2 inhibitor. I mean, the non-selective or the selective one. The non-selective, ibuprofen and naproxen, they are very useful because particularly in the high-risk patient who has got other comorbidities like cardiac or stroke or things like that, because then they have less chances of prothrombotic. And also remember the NNT of these drugs are very low, so they are very potent. So the commonly used drug in cancer pain is anti-inflammatory drug would be and maybe naproxen. That's what we commonly use. We'll combine it with paracetamol also, because that will ease the side effects. That's what we commonly use.
What about the addiction to these drugs, madam?
There's no addiction.
No addiction to these drugs.
No addiction.
Unlike the morphine
Unlike
and all.
The strong opioids and all have addiction. This has no addiction. But just remember, when you're giving NSAIDs, I told you about all the high-risk cases where you should avoid NSAIDs. And also, when you're giving NSAIDs, ensure the hydration is adequate. Because if the hydration is not good, the renal side effects are much patient can have. So you have to check about all the comorbidities, age, etc. when you're giving NSAIDs. That is a drawback of this. And also, when you want to give it for a longer duration of time, you have to avoid NSAIDs. You can't give NSAIDs for 1 month and 2 months. Maximum, you can give it for less than a month. not more than a month. Long-term basis NSAIDs cannot be given because it will have the side effects.
Okay, thank you, ma'am.
Madam, I have one query. Can you hear, madam?
I can hear, but what's your name? I can't get it.
Yes,
Sorry, ma'am.
please go
I'm,
ahead.
Okay,
I'm
okay.
the Gyan. Gyan.
Acha, right.
Ma'am, how will we start the analysis letter for a patient with pre-existing renal failure, having only mild to moderate?
Okay. So in such patients, avoid NSAIDs. Okay. Even if it is creatinine is a borderline, creatinine clearances, don't avoid NSAIDs. So the drug of choice in these patients would be paracetamol or tramadol. If the patient is having mild pain, you can give step 1 drugs. If the patient is having moderate pain, you can give tramadol that is quite well tolerated in these patients. And if the patient has got very, very severe pain, then you can give fentanyl infusion or fentanyl pads or morphine in low doses. Or methadone. Methadone is even better, particularly those.
Thank you, ma'am.
But mild pain, paracetamol is the best.
Best.
Madam, there are few questions in the chat. I will read them for you. First one is etoricoxib free of cardiac side effects?
So I told you, no, you should not give it when there's a cardiac problem. See, that is a drawback. Because if the patient has got a high-risk cardiac case or high-risk neurological case, you should avoid a selective nurse. Etoricoxib has to be.
Okay, next
Then the
one,
drug
madam,
of choice will be either Brufen or naproxen. They'll be good. Or paracetamol.
Next one, if the patient is asthmatic, giving NSAIDs will activate the 5-lipoxygenase pathway to induce
Yes.
activation
It will cause allergic.
What will be the drug of choice in these patients?
Drug of choice, you avoid a non-selective.
NSAID.
You can give selective COX-2 inhibitor. Like etoricoxib or celecoxib or paracetamol.
Next one is also like similar to the one. What if the patient is allergic to NSAIDs? You avoid that was the next question, ma'am.
See, patient is allergic to paracetamol and diclofenac. Now, I've never seen allergy to paracetamol, but there is one person I know who's allergic even to paracetamol. It's not that paracetamol is completely free of allergy. And it's very rare, but there is a person I know who's allergic to paracetamol. It's very difficult to treat these people when they're allergic to paracetamol. Then you may have to go in for tramadol and things like that. But anti-inflammatory drug, paracetamol is not anti-inflammatory, so that is a drawback.
Next one, what will be the drug of choice for oral cancer who has a problem of mild renal problem?
Or may I know the question once again, please?
What will be the drug of choice for oral cancer who has mild renal problem?
Okay. Oral cancer. You can give paracetamol, but only thing if they can swallow. I'm not sure if he can swallow or not. But if they have a mild renal problem, then you can give
Tramadol, paracetamol, they can be given in titrated doses, isn't it,
in
madam?
titrated
And then
doses it can be given. Yes.
Depending on, see, these type of patients you have, but I'm sorry, I'm just trying to explain only.
Yeah, definitely. Please, Radha.
Okay, basically these, see, you will face these type of issues. So then what you have to do, see the patient as a whole, what is the severity of the pain. So if it is mild, then you start with paracetamol. Okay, if paracetamol is not sufficient, then you check the renal parameters. And then see, always when you have renal issues, the standard few options which we always say is increase the duration. Instead of giving TDS, make it BD. And then dose also you reduce that. These are the two standard goals to be practiced whenever there is renal issue. So that is what you will do. So basically use low dose and give longer gap. This is what is called as titrating the dose according to the patient's condition. So those are things which you can. And oral cancer, then next you see patient can't can't swallow solids, can't swallow liquids. For everything there is alternative. See, if they can't swallow solids, go to either liquid paracetamol. You get a pediatric syrup. Same things are available as 5 ml containing 250 milligram, 5 ml containing 500 milligram. So these are the things which you have to look at. Then you have IV paracetamol.
Rectal
So
paracetamol.
many options.
Rectal also.
Rectal paracetamol. Yes, I was now. So but see, even in the previous batch, I was telling about PR diclofenac, madam, which see, that is one alternative you can use. And being an anesthetist, we use these, basically I'm also an anesthetist. So we use this regularly for pediatric patients who can't take medications post-op. So we will give them diclofenac or paracetamol, PR, and send the child so that the child may be crying, not taking the analgesic. So rectal, so many routes are available. Oral can't swallow, then liquid, first option. One more thing also is that you can powder the tablet and mix it with honey and something and give. So there are multiple modes of delivery.
Or if they have a rice tube, you can give it through the rice tube.
Yes, so that's what. So there are so many options. So mostly oral cancer patients may have a rice tube. And so umpteen options are there. Not that we have to put all these into perspective and give some analgesic which will ease their pain. Okay, there are some more, madam. I'll just read them and then we'll go to the case discussion. Patient, how often, did I miss anything? Allergic to NSAIDs. Renal problem is what we were talking. How often do we need to monitor the renal function of patient on NSAIDs?
There's one question which I want to answer is, can we use corticosteroid as a primary analgesic? Please don't do that. I don't think it should be used as a primary
No, not at all.
Always the WHO analgesic ladder, and if there's an indication for corticosteroid, only then we do. And also, remember, corticosteroid cannot be given for long. Maximum you can give it for 5 days. That's it. Or you have to taper it off after that. So it's only, like I said, only when it is indicated, you should give it. Okay? It should never be used as a primary analgesic. Primary analgesic is always the WHO ladder.
WHO ladder. See, that is to standardize care and practice. See, if you follow this WHO ladder, you will have uniformity. This is followed all over the world, all over the globe, so that there is some uniformity. See, there is some, it's like a format or protocol available for you to go step by step so that you deal with it appropriately and patient gets the benefit. And then how often do we need to monitor the renal function of patients on NSAIDs?
See, NSAIDs, I told you, you don't give it for too
long time.
I told you, I don't give it for more than 2 weeks. Okay, so you can monitor at the end of that, but then more than anything, it's important that the hydration of the patient is good. Then you can avoid the renal side. But never give it on a long-term basis.
NSAIDs are used right, left, center, but that is not the way they are supposed to be used. All of you have to see patients who end up with such bad renal failure, end up in dialysis, because without their knowledge, they would have been on NSAIDs. Recently, I had been to Andhra Pradesh and where I saw so many young 30-year-olds on dialysis 3 times a week. Only thing, they've been on NSAIDs for very, very long time. See, multiple factors are there. I'm not telling that's the only thing.
I have seen people with rheumatoid arthritis at all. The rheumatologists do put them on NSAIDs long-term basis, particularly the selective NSAIDs.
Naproxen.
So like selective, that is Nucoxil. They are on that for a long time, but we have to be very careful. In that case, we definitely have to monitor renal function every 2-3 months.
See, these type of patients, when they're on renal and liver function, so these things have to be checked. Like these, when they are on these type of medications for long, you will have to check them depending on what is their main underlying disease, how long they are taking. Again, all that also multiple factors have to be taken into consideration. Next question: patients
Well,
allergic to paracetamol and diclofenac with inflammatory pain, which drug is advised?
then you may have to go on to step 2 drugs that are
Some
tramadol
other,
and things like that.
correct. If not,
And
next then to go to step 3 drug based on
Yeah.
how and where they are. Because the morphine titrated dose has less side effects than all of this. So that
but
is where,
the problem with strong opioids is how long can you give them?
correct.
So,
See,
I mean, we
once
have to be
you,
little careful when you go on to the strong opioid. The weak opioids are preferable.
and then adjuvants, you will, if you use the adjuvants, they will do like they will have additive effect.
Co-analgesic, they are co-analgesics.
So together they will give. So that is where the adjuvants come hand in hand, and they are very useful. And when you start the adjuvant, you will be able to reduce your dose of the analgesic. That is the main reason why adjuvants are started. And when you practice and use, you will see the benefit. We have used and we have been able to reduce the dose of the analgesic.
And
And
this question,
steroid.
how to detect cases of malingering pain.
Mm.
Now, there is one basic dictum in pain, or particularly even cancer pain. If the patient says, I have got 9 out of 10 pain, we have to believe them. So generally, that is supposed to be the most accurate measure of measuring pain is a patient's own report of pain. So malingering is not very common unless a patient is getting benefits from his office and things like that. If you have pain, then you don't have to go to office, you get the compensation financially, but very rarely you have malingering patients. I've not known.
You have to get an overall history. There will be some other, if you take a history, there will be other psychosocial issues or attention-seeking behavior, so many other things. So it is just not one thing.
Otherwise, the patient's self-report is supposed to be the most accurate measure of pain, actually.
Because we say it's a subjective phenomenon, so you have to see. So there comes our additional skill to find out what are the other things, and you can pick up very easily the amount of drug they use and the way they present, what they give importance to. That is what is our skill. You will all be able to do it, and by practice you will get it. Okay, can we go on to the case presentation then?
There's one question that I'd like to answer is, will it be fine to use opioids for rheumatoid arthritis patients instead of NSAIDs?
I didn't see
now,
that,
that
madam.
is a totally different ballgame altogether. Because the use of opioids for non-cancer pain has to be very, very judicious. Because these are the people who are going to, maybe young person, be going to live for 10, 20 years. How long can you give opioids? And rheumatoid arthritis is not something that will peter off. Okay. So when you want to use a strong opioid for non-cancer pain, very, you have to take the decision very, very cautious. I, for one, don't use it for non-cancer.
Exactly, madam, because I would just like to say the plus of opioids are also there. The negative of opioids are also there. When you use opioids for very long period of time, very, very bad or serious side effects also come. They affect the hormone balance. There are so many things.
There's an opioid epidemic happening in the West, and people are dying of opioid overuse.
It affects the immune system also. So very 3 important things to be borne in mind. So every drug has to be used appropriately to get the best benefit out of it. So using opioid for non-cancer pain has to be done very judiciously. That is where our step ladder helps. On all other things you have used, and then even if you use morphine, you use it only for short time, come out of it. So you have to, before starting itself, you have to have all this in mind. So especially with rheumatoid or these type of chronic inflammatory disease, normally opioids will be thought umpteen times and whether it is, and I don't think it is widely used. other
we can move
methods
on to
only.
the case presentation.
Yes, yes. Thank you, madam. Sorry, I had not seen that question because that had just come after we. Shripriya, can go ahead with the case presentation, please.
Is it visible, ma'am?
Yeah, it is visible. Yes, sir. It is visible, sir.
Yes, yes. Go ahead.
Oh,
Go
okay.
ahead and
Yes.
start.
Good evening, everybody. Today, I'll be presenting case on management of pain using NSAIDs. This 81-year-old female with traumatic paraplegia with presenting complaints, aggravated pain along the right lower limb from 3 months. History of illness, she had history of fall from bed 2 years ago and suffered from fracture of lumbar spine at L3, L4. She is a known case of hypertension from 15 years and also known case of osteoarthritis from 6 years. She has malunion of fracture site leading to spinal nerve root compression and has sharp pain in the right lower limb. Since then, she is bedridden and not able to perform daily routine. She feels tired. She is taken care by a daycare nurse. On examination, she is well oriented to time, place, and person. She is moderately built. Pallor is present, but no icterus, cyanosis clubbing, and leukodynopathy. She is able to move her upper limb, and the lower limb she is not able to walk. Right lower limb pain and paresthesia is more compared to the left lower limb, and motor deficit is there in both the lower limbs. Pulse rate is 76 beats per minute, and blood pressure is 140 by 86 mmHg. Respiratory system, normal vesicular breath sounds heard and no abnormalities detected. CVS S1, S2 heard, no murmurs and no abnormalities detected. X-ray findings show fracture at L3, L4. Treatment, she being hypertensive, she is on tablet Depin Retard 20 mg OD. And because of the pain, earlier she was given ibuprofen for 1 year, for which she had GI disturbances. So now shifted to piroxicam 20 mg for 3 months, tapered to 10 mg per day. And piroxicam is given because pain tolerance is better. And it is also drug of choice for lumbar osteoarthritis. And because pallor is present and she feels tired, Tex Orange 10 ml per day OD for 1 month of the food is prescribed. Significant investigations, hemoglobin, complete blood count, C-reactive protein, blood urea, serum creatinine, liver function test because she is on NSAIDs for quite long, renal function test, and lipid profile. Psychosocial aspect, she is a middle class lady with 2 children, son and a daughter, both married and well settled. She is a widow and son takes care of her. Medication, she is presently on capsule Parox 20 mg, which is NSAID of non-selective reversible COX inhibitor, used to relieve inflammation by preventing production of endogenous prostaglandins, which mediates pain, tenderness, and swelling. This drug gets metabolized in liver by undergoing hydroxylation, glucuronidation. Piroxicam is preferred because it has a half-life of 50 hours and is a drug of choice for osteoarthritis, rheumatoid arthritis, inflammation. The adverse effects of piroxicam, it is similar to other NSAIDs like ulcers, bleeding holes in stomach, intestine. NSAIDs other than aspirin can also cause MI. Piroxicam, because its half-life is 50 hours, it is prescribed 1 tab a day. Other NSAIDs given in rheumatoid arthritis can be ibuprofen and naproxen. So piroxicam is used to relieve pain, tenderness, stiffness. Next slide. So main concern is to restore quality of life. So summary, she is an 81-year-old woman with traumatic paraplegia with pain over right lower limb. So we'll be discussing regarding palliative care and the problems faced and what more can be done for this patient. Thank you.
And thank you, Dr. Banu.
Yes, sir.
You can take one by one, and everyone could give their input regarding palliative care for this patient. They can either type or do. And what is that like? What all are being done from the patient's point of view, and what you could summarize, please, just what is done for the patient at present?
At present, ma'am, she is bedridden. She's taken care by a nurse. They're using diapers also for her. And because her main complaint is pain, she's on pyrox.
Only pyroxicam.
We maybe nutritional support, more of proteins in the diet, and even physiotherapy maybe of some use to her, and psychiatric.
What is her pain score with the pyroxicam?
Pain, she is not getting totally relieved, but she feels better with the pyroxicam.
So no one has scored, and what was it before and what was it after starting the pyroxicam?
No, ma'am.
Have they added paracetamol along with the pyroxicam anytime?
Okay, ma'am. Yeah,
have they tried? I'm asking.
No, ma'am, they have not tried. Because she was trying, she was feeling better with this. Because paracetamol, she may again develop gastric irritation. So I haven't tried out.
So for pyroxicam, she doesn't have any side effects?
Yeah, ma'am. She is okay with it. Yeah.
Okay, and someone I think had typed about prevention of bed sores. What are the other things to be?
Not like exactly bedridden, ma'am. She can incline at 45 degrees also. At times. Yeah. She's
with
not
support
like totally
or by
bedridden.
herself?
With support.
So in that case, are they able to move her from bed to chair or something like that?
Yeah, ma'am.
Oh, she is able to do that.
Yeah.
So in that case, like to her personal needs and all, is she able to?
Ma'am, they're not doing actually, because lifting her again.
That is because of lack of manpower, or what is the?
Ma'am, they do at times, and at times they don't do. Yeah, manpower.
When you want to assess this patient, you have to see whether the pain is, you think it's a mainly neuropathic pain? After having explained what is nociceptive and neuropathic, do you feel that the pain in the right lower limb is a neuropathic pain? Yes?
Yes, sir.
So at the end of the lecture, what have you decided? Would you think that an anti-inflammatory drug is enough for her, or do we need to add a drug for neuropathy?
Ma'am, I think antidepressive also would be useful.
Anticonvulsant, antidepressant, one of the
antidepressant.
Yeah.
Antidepressant would be helpful because she has some, I feel she has psychiatric issue also. Like she feels, she cries if she sees people. So antidepressant may help in pain as well as maybe
in treating the neuropathic and the neuropathic component also. So what is her sleep? Does she sleep well at night?
Yeah, ma'am.
She sleeps well?
Yeah.
No pain at night, no? No pain at night?
Yeah, because she's on pyroxicam, ma'am.
So I think in this patient, we need to add a drug for the neuropathic component. So to assess a neuropathic component, you have to know the type of pain. You said it's a sharp pain. Is it associated with tingling, numbness? Is there
Numbness,
burning? All these things have to be asked. Okay.
Yes.
If it's a sharp shooter, if it's a neuropathic pain, there could be tingling and numbness as well. If
Yes.
there's a root compression. So in that case, you add a anti-neuropathic drug that either an anticonvulsant or an antidepressant. Even anticonvulsant can cause sleep also, but antidepressant has an added effect that it will take care of anxiety, depression.
Okay.
And so this can be added, and then whether this piroxicam can be given on a long-term basis in an elderly 81-year-old lady, it's a little worrying. So
Yes.
paracetamol can be tried. It does not produce gastric irritation. It's piroxicam that can produce that gastric irritation, not paracetamol. So you should always start with an elderly lady. If she's managing well with the paracetamol, then that would be preferred over piroxicam. Okay. But you must add a adjuvant drug to her definitely. And she will need psychological help.
Yes, ma'am.
To counsel her and take care of. Not psychiatric. Psychiatric is different. You know, they will add medicines. Even psychological support is all that she requires.
Okay.
Along with your medications.
Fine.
And like Dr. Radha said, we need to document the pain score.
Okay.
If the pain score is less than 3, 4, that means you got good relief of pain. Right? But if it is higher, then we may have to, like you're giving piroxicam, how much has it come down? See, it will also help to know whether your treatment is efficacious or not if you're monitoring the pain score.
Okay.
Thank you, madam. Exactly,
Thank you,
that is what is needed. So the thing is that you need a bit more assessment. The pain assessment itself has to be done a little bit more. And then all what I'm not going to repeat what madam has said. Adjuvants do have a very big role. And once again, we say reassess, assess, give something, reassess. So your reassessment has to happen once in few days until the pain settles. And then also multimodal management, counseling, and then 81-year-old. We have to have goals which are possible and achievable. You have to explain to them. They have to also be aware, and family involvement. So if they can give a little bit support in different times of the day. So multiple factors are there to be considered here, and then assess, reassess. Paroxicam continuing on long-term basis has lot of side effects than paracetamol. So all that has to be considered and then done appropriately. Okay, what are the problems faced by this patient? So this one, as like her mobility is reduced, as someone mentioned, bed sores is something you said, but she is moving. In that case, we have to, like in the sense, she sits up so regular. Like you will have through your sessions, you will have nursing care elements also in the lectures, which will throw more light.
Lady. Yes, ma'am.
So those also have to be. I'm just in conservative management, including nutrition, bed sores. Yes, I'm just reading what are the things in the chat. What is the maximum dose of paracetamol given in a day in an adult for pain? In pediatrics, it is 2 grams, the max dose. 4 grams per day is the max dose for paracetamol. But generally, like, see, that is the max dose. Like, you can give 650, no? That Dolo 650, what you get, you can give 4 times a day. So something like that. Her, we have to keep in mind, she's 81-year-old. Like Dr. Usha had asked, what is the dose? That is 4 grams is the dose, is the maximum dose. And then physiotherapy can be, passive exercises can be taught or done. And the next she cries means she needs psychological rehab. That's what madam also said. So looking into that and seeing what can be done and then appropriately dealing with.
Like you said, it's just like a total pain management. Just remember that she has got physical pain, she's got emotional pain, she's got social pain, and possibly even spiritual pain. All have to be addressed in her. Maybe she would have liked going to the temple or something. Now she's not able to go. Or she thinks that pain is because God is punishing her for something. Or have I done something wrong why I'm suffering from pain? I don't want to live anymore. So that's all spiritual pain, right? So we have that also needs to be addressed. We have to tell her it's not because of that you're having pain, but we'll try to make it as better as possible. Social issues are, if she can interact with people. And does she feel happy watching the television or, being around company? And she can be mobilized, like someone has mentioned. She's in a chair, then she can be taken even out, not in the four walls of a room. So that mobilization also can be done possible. Of course, you should treat the pain, physical pain, but you have to look at the other issues that are, also adding to her pain. It will all add to the pain. Okay.
There's family interaction, no? Many times they're just in one room.
Yeah.
If they are also made part, like when everyone is having a meal or something, to bring her also, so that she gets to talk, so that everyone speaks to her. She's not left by herself. These are things, no? These are they will have practical issues. Everything easy said then done. That's why I said manpower, and then a little bit of education. They would have said, they would have thought, oh, leaving her there maybe was for her comfort. Yes, but is that what she wants? So multiple things like this are there. What she wants, what can be done, also to be taken. Let me read the other few things which have come. Mobilizing in wheelchair is what we were telling. So she had GI bleed from previous drug. Is gastric protective measure taken? Always when these type of strong analgesics are given, gut protection is a must. Okay, that is one of the reason why you don't keep on giving these for long period of time. Okay, and what are the other options apart from paracetamol in this case? Tramadol is the next option. Like adjuvant first try, and then if adjuvant is also not helping, then go to next level. You can use weak opioids.
For that, the pain score is very important.
First, exactly, we don't know. That's why my first question was, what was the pain score before? Now, so that is why assess, reassess. If, see, for example, you assess, reassess. Oh, no, everything is something out of the way. Then go back. Nothing wrong. Go back, start from history. Is the first diagnosis of our pain element right? Where are we missing something? Nothing wrong. We have to go back and see what has to be done.
Okay.
There's a question here. Since it's traumatic paraplegia, is it nociceptive pain? It is traumatic paraplegia will only cause neuropathic pain, not nociceptive. I told you a lesion anywhere in the nervous system, it will cause neuropathic pain. So it is not nociceptive. Please take that out. It is only neuropathic pain that you get after paraplegia.
Traumatic. See, that is how, there the pathophysiology of pain comes. Pain pathway, the whole problem is it is not a hardwired system. It doesn't happen or the way we think alone, because there are so many mechanisms constantly. Some basic, for all of you to know, will be peripheral mechanisms, central mechanisms. So sensitization, and then one is sensitization. Next, something is called as wind up, aggravating or amplifying. So what was more, this is all done happens within the nervous system. So that is one of the reasons why we have pain in all these forms. It is just not simple and straightforward, only one pathway. There are multiple ways how it can happen. That is what it is. So in the broad perspective, for all of you to remember, you have mechanisms which happen peripherally and mechanisms which happen centrally. Both have sensitization, and these things wind up. There's something called as wind up. What it is, simple word, it is just amplification. There also it could be an amplification which is short-lived, and it could be an amplification which is long lasting. Amplification, just English word. What? It exaggerates, makes it big.
Radha, I have a slide in which I can show that. Can I
yes,
do that?
Please, madam. Yes, please.
Then we'll have to stop that screen sharing.
Yes, you can go ahead, madam.
Just 1 minute. I'll just put it on.
No problem.
Because that
Something
will
useful
show.
for them.
Yeah.
Exactly. Useful.
Not so simple. And there is multiple areas of the brain where pain can go. See, the pain is starting from here, but it goes not only to the sensory area, but it goes to the motor area because the withdrawal happens sometimes when there's pain. It goes to the limbic area, which is the amygdala, hippocampus, causing all the emotions of pain. It goes to the prefrontal area, which is actually understanding that pain and the thought processes behind the pain. It can affect the pineal gland and it can cause sleep disturbances. It can cause the hypothalamus and cause all the reactions to pain, like lack of, flight and fight mechanisms. So it's just not a simple thing that it only goes to one area. It goes to multiple areas in the brain. And that's called a network of pain. The pain, and this they have found it on functional MRI. When they have done
fMRI.
functional MRI of a patient with pain, they found not just one area lighting up, but several areas of the brain that's lit up. So pain is very complex. Okay. I just wanted to show this.
Thank you very much. Exactly what I was trying to say is what. And these, as Madam said, I've seen many pictures and screening. These fMRI, like what they do is they have the patient, they do active fMRIs when the patient is conversing and things like that. So they are in pain, they are upset. So that time, and their next stage is that chemical mediators also have been linked. Low mood, high pain. So the same chemical mediators are also seen in the brain. So there is enough clinical and all forms of scientific evidence to show this. The latest, what Madam said, is what I was also trying to say. Thank you very much, Madam. Always pictures go a long way. Okay, for this simple clue, I will tell. All of you see one movie trailer, one shot you see, and then you imagine the whole movie. So pictures, what are seen, are stored by us very well. Okay. So thank you very much. So that is what it is. It is not just prick, afferent pathway, brain, pain. That is one mechanism. That is for nociceptive. Whereas for pain, why? That's why the definition, everything, it is not simple. It has got multiple components. And the one simple word is it's not a hardwired. So it is a neuroplastic. So it has multiple changes and multiple ways it modifies and presents. So that is why the neuropathic element will be there in most, especially cancer. It is known to have cancer has very big amount of neuropathic pain. And any pain which lasts for more than 6 weeks, 12 weeks has a neuropathic element. So all these have to be kept in mind. And when you know the mechanism, any of this, if you read a little bit more, there are ectopic, self-firing, so many things are there in it. So all that can be one of the causes. So neuropathic element will be there and they will benefit from adjuvant medication. Anything else is in the chat? Let me quickly have a look, Madam. Couple more are there. Yeah, just explanation. Okay. Thank you, Madam. Your drawing was very good. Simple, but that's what it is. Sometimes just we have to convey what is needed.
This is a drawing for my next book.
Very good. Thank you. I don't think anything else is there in the chat, Sri Priya. I'll hand it over to you.
Thank you. Just a moment. Thank you everyone for joining in today. Hope everyone had a better understanding about the management of pain using NSAIDs today. And with the promise that we will meet again on the next session with the second part of pain management using opioids. This is Sri Priya along with Dr. Mary Abraham and Dr. Vrata Venkateshan signing off from the Tips Eco Hub. See you in the next session. Till then, everyone take care. Bye-bye.
Thank you. Thank you very much, Madam.
Thank you so much.